what is GLP-1? Glucagon-like peptide. This is a hormone that's released in your gut whenever you've eaten food. So you eat food, your gut senses it, releases this hormone, and it says, all right, we got some food, you can stop eating, and we're going to slow down the motility because we need to absorb this, right? So if you eat a piece of bread, it gets digested in your stomach, you're releasing hydrochloric acid, and it's jumped into your small intestines, and then you're releasing pancreatic enzymes, you're releasing bile, if it's fat, depending on whatever you ate. These things get absorbed in your bloodstream, right? And in particular, let's just say that glucose is sugar. Then your body releases insulin, and insulin tells your body, all right, let's store this. Let's put this away. Let's put it in your liver. We turn it into glycogen, put it in your muscles for glycogen. And so when GLP-1 is released, main thing we're going to see and why these drugs are so effective is just going to decrease your appetite. You end up tricking your body thinking, oh, I just ate, right? So when you do an injection and this hormone is elevated, the agonist is the actual hormone isn't the receptor that's being hit. You go, oh, wow, I need to eat. And that works out for a lot of people, science that it is weight loss is just calories in versus calories out. It's pretty simple. The hard part and the more nuanced part is when you are messing with your hormones, how do we manipulate or use those to our advantage? Like I was saying with thyroid, you can lose weight on low thyroid, but you're going to be miserable, right? Like if you have high testosterone and you have massive amount of muscle, your basic metabolic rate is going to be higher. And that's one thing that we have to take into consider when we're using these is you don't want to lose your muscle, especially in the long term. I talk to my patients about this all the time. Like very rarely after 25, does anyone lose weight? Does anyone put on muscle? So while we say, hey, you're a 50-year-old and you got on one of these and you lost 20 pounds, but you lost 7 pounds of muscle, I don't want you losing 7 pounds of muscle in your late 50s. As you age, muscle and strength are going to be one of your best markers for longevity. So what are the benefits of these? You're going to have better glucose control because you're not overly stuffing your face. In the short term, having a quick influx of carbohydrates nukes testosterone. There's like one study, it drops about like 50% in like 60, 80 grams. And the reason for that is you have a high amount of sugar, your blood sugar goes up, you release insulin to drop it. And the idea is that it drops so fast, then you overcompensate, and then you release like glucagon and cortisol to bring it back up. And then cortisol is going to work against your testosterone. So again, this is kind of playing into that conversation about leveraging your hormones. Now, the vast majority of the benefits is coming from just decrease in caloric intake, and in particular, regulating your blood sugar. And that's going to reduce your cardiovascular risk in the long term. With Liraglutide was the first one I heard about. They actually showed a decrease in carotid artery thickness when they started Liraglutide, which is super promising and cool. But again, with lower blood sugar, that's going to be easier on your kidneys. You're going to have a better lipid profile, less likely to get fatty liver, and just going to be overall less inflamed. And that's going to be good for your brain. It's going to be good for your joints. It's going to be good for everything. Alzheimer's, they're basically saying it's kind of like type 2.5 or 3 diabetes of your brain. It's just poor blood glucose regulation. And so it's a good idea to try and keep your blood sugar down, especially from time to time doing fasts. These medications can also be helpful for that because you're going to fast because you're not hungry. One of the other more unique characteristics of the GLP-1 is it acts on the osteoblasts. These are cells in your bones that tells your bones to get stronger. And then also having weight loss is going to be easier on your bones. Now, side effect wise, what are the major side effects of these? Well, you can imagine if you're slowing down your digestion, not going to feel that good. I mean, it's no different than if you just eaten too much and you're sitting around after a meal. You can be nauseous. You can actually have vomiting, diarrhea. You can be constipated. And if you're already having GI issues, pancreatitis, gallbladder issues, this is probably going to exacerbate them. That's probably why you don't want to be messing with these. Liraglutide had some studies on thyroid cancer, which we'll talk about. One of the major things I've talked about already that I'm most concerned about is the loss of muscle mass. The other thing, again, in particular with Liraglutide was the worsening diabetic retinopathy. It's where you have blood sugar regulations and endothelial blood vessel issues in your eyes, right? And it leads to destruction of your nerves in your eyes and being able to see, and you can go blind. There are some class action lawsuits where people are trying to sue. If you have diabetic retinopathy, and even if you have probably like diabetic neuropathy, like, yeah, these can probably worsen that. So I'd probably stay away from them. Not medical advice, talk to a practitioner. I'm not your doctor. But I quoted one in particular study showed a 76% increase in the diabetic retinopathy. The other thing long-term that people are concerned about is long-term delayed gastric emptying. There are people, I think, too, kind of class action lawsuit who are like, I can't eat whatever I want anymore. It's like, you probably shouldn't have been that way anyways. But ultimately, they are like, hey, my digestion slowed down so much. Now I'm uncomfortable when I eat anything. And this is even after coming off of them. The other thing I meant to include in the slideshow I didn't get to was talking about naturally when you're releasing GLP-1, glucagon, and GIP, the concentration of that compared to the drug. My understanding, I don't have the exact stats in front of me, is that these drugs are far, far more potent than your natural production, which makes sense for most hormone replacement therapy. I would just bring that up because then we don't know kind of like long term, right? We don't really know long term. Most of these drugs, they're really only being used for like 15 years. There are some people out there who are like, oh, we're really going to regret this. I don't know. I'm not all that. I mean, it's life. Everything, there's risk and benefits to everything. You just have to go with it. And I would think someone who's like 60 years old, it's like, and you're overweight, you're probably better off trying one of these than living into your old age and not losing weight because that's going to cause all kinds of issues, just metabolically, heart problems, blood pressure problems, not working out. And so if you use these as a crutch in the meantime, lose a bunch of weight, cool. It really depends. That's why you need to meet with a practitioner and weigh out your risks versus your benefits. We'll break this down. I have on this chart a lot of the different GLP-1 agonists. I just want to highlight a couple of them. Liraglutide 600 was the first one that I knew about. Drug-wise, we'll get into the dosing. That was the first one I remember learning about. And then more recently, the Semaglutide became more popular. So I have the dates on there, right? 2010 for Liraglutide, Semaglutide was 2017. Now, again, I'm not your doctor, so chat with your practitioners about dosing. My opinion, I think a lot of people start off way too high on these. And unfortunately, these drugs are very expensive, whether it's through insurance or cash pay. So I think there's a subconscious incentive to get people to go higher because there's larger profit margins. Just my 2 cents. So with my patients, I start them even lower than what these starting doses are at. So something like semaglutide, if you're going to start at 0.25 once weekly, like why not start at 0.1? Why not? Because if you're taking this just to curb your appetite, it's kind of like if you're tired, you're like, well, go do a line of some Colombian Ban or do a cup of green tea first. And I'm not recommending that. I'm just like trying to watch myself. Like, can I say that on YouTube? Or just like a Red Bull. It's like just start with something like green tea that gives you enough energy. Great. So with the liraglutide, like why not just start on a lower amount? And what's that? Oh, the oral Ribellicis. I haven't really messed with that one, but I have the lower dosing here, like on semaglutide. Most people are starting at like 0.25 milligrams once weekly, and then they're going as high as 2.4 milligrams. Oral, you're looking at 3 milligrams as high as 14. I don't like going up to those higher amounts, but people do them. Contraindications, like reasons you wouldn't do this: medullary thyroid carcinoma. We'll talk about that in the multiple endocrine neoplasia in the next slide. You got to be careful if you already have blood sugar issues, you're on other diabetic drugs. We already talked about diabetic retinopathy. If you're at risk for already being hypoglycemic, meaning your blood sugar is too low, you've had diabetic ketoacidosis before, like talk to your practitioner. You can't just be allergic to these drugs. You can be allergic to any drug. So hypersensitivity. If you already have some form of like severe GI disease, I wouldn't know why you would mess with these: colitis, diverticulitis, Crohn's. If you have hemorrhoids from being constipated, pancreatitis, gallbladder issues, all these things, most likely there's a good chance that the GLP-1s will make them worse. Not always. If you have kidney or liver issues, in general, you're pregnant, breastfeeding, I stay away from them. Heart conditions, the safety is still like not up in the air. We'll talk about glucagon. There seems to be retatrutide, some concerns there. Maybe not so much with the GLP-1s. If you're already skinny and old and you're not getting enough calories to begin with, or you have an eating disorder, like say probably I would look somewhere else than using these. Basically, in this slide, I kind of just break down those with liraglutide specifically. They had found an increase cancer, medullary thyroid carcinomas in rats and mice. The issue with that is in rats and mice, and the thyroid and the C cells, they have more receptors to GLP-1. So that what happens is GLP-1 stimulates in the thyroid, and then you get a release of calcitonin, and somehow that ends up giving you medullary thyroid carcinoma. Super debatable. So that, and with the multiple endocrine neoplasia, which is also messing with the thyroid, you just say like, dude, stay away. Like, why risk it? Still controversial, but the FDA says, hey, we don't have long-term data. Be careful. I just also then put drugs, if you're already on some other diabetic drugs. DPP-4 inhibitors, it's an inhibitor that breaks down the incretin hormones like GLP-1 and GIP, so you really wouldn't want to stack those together. Taking these is going to slow down your motility and or absorption. So if you're taking like a thyroid medication, levothyroxine, acetaminophen, like Tylenol, you take a Tylenol, it's like, it's not working. I'm going to take another one. It's like, well, it's because your digestion slowed down. Could mess something, warfarin, contraception, oral contraceptives, antibiotics. Just be aware that this can slow down your absorption of them. And then kind of supplements, you want to be careful. Fiber can make things better or worse. Calcium and iron can mess with absorption. Blood sugar herbs like berberine, fenugreek, and cinnamon, stacking those, those are great herbs. I think berberine, even in itself, has a little bit of GLP-1 agonist to it, but you probably don't want to stack them. Again, talk with your practitioner. And then there's something with St. John's wort and the metabolism. I don't think it's quite clear whether or not they messes with the metabolism of the drug, but it's worth mentioning. And if you found this topic interesting, I think you'd like this other video that I did. Thanks for stopping by. Until next time, stay vigilant, my friends, and God bless.